Dashiell, and my project is the assessment of brachytherapy dose distributions relative to VMAT and electron therapy using a 3D printed forearm. This is specifically for skin lesions. So just an introduction on skin cancer. Australia has one of the highest rates of skin cancer across the world, with 2 in 3 Australians being diagnosed in their lifetime. And non-melanoma skin cancers are actually the most diagnosed cancer in Australia. However, these don't often appear on incidence reports because they're not reportable by law to cancer registries. These are usually caused by modifiable and non-modifiable risk factors, being things like exposure to UV for modifiable or genetics and skin tone for non-modifiable. So these are classified into melanoma and non-melanoma skin cancers. So melanoma accounts for about 5% of these, whereas the other two, the non-melanoma skin cancers, are usually broken up into basal cell carcinomas and squamous cell carcinomas, which account for about 95%, and then other rare types of non-melanoma skin cancers are the rest of the 5%. So 70% of non-melanoma skin cancer mortality originates from squamous cell carcinomas. This is due to their more aggressive nature in more progressed lesions, but this can be stopped if treated early. And then melanoma actually accounts for the most skin cancer-related deaths. So just a bit of background into brachytherapy. It's a treatment type that utilizes sealed radioisotopes to deliver radiation across short distances. As shown by the picture, this can be intracavitary, interstitial, or superficial. And then these can be either temporary or permanent, low, medium, high pulsed dose rates, remote and manual afterloading. And so specifically, high dose rate superficial brachytherapy uses custom or industry-made applicators for skin cancers. And most of the time, and here at Charlie's, we use iridium-192 sources, which produce gamma from the main interaction, which is decay to plutonium, as well as the electron capture to osmium. So we have a couple of traditional superficial applicators. These are surface mold, surface flat, radionuclide shielded, and electronic shielded. So the surface mold are usually made from wax, acrylic resin, or gypsum and are molded to the patient's surface. The surface flat are utilized for skin topography and placed straight onto the patient. Radionuclide shielded for smaller tumors and made of tungsten to reduce absorbed dose elsewhere. And the electronic shielded is less so a brachytherapy treatment type. It doesn't use radionuclides and delivers low dose X-rays instead. So there's a bit of relevant literature around this. Mainly, the first one is reducing air gaps. So Casey et al. Demonstrated the difference in air gaps when 3D printing applicators compared to using traditional surface molds, which can be seen on the right in the top picture. The air gap on the left with the regular surface mold and the reduction of that on the right. And it was shown by Casey that this actually improves the dose distribution with less air gaps in there. And Poltorak et al. Quantified the error in 3D printed applicators, noting placement error being less than 1 millimeter on average, with average air gaps of 0.4 millimeters. Another advantage of this is the catheter placement, which Jones et al. Demonstrated that poor CTV coverage at skin doses can be improved by optimizing catheter placement. And this is changing the orientation as well as the depth at which they are placed. And then economic benefit, Arenas et al. Conducted a financial study into the clinical application of 3D printed applicators and found that it reduced workload time by 34%, waiting time by 57%, and labor cost by 28%. So the problem identification of this is the forearm is a common site for non-melanoma skin cancers outside of the head and neck region. And within the literature and hospital practice here, there's no current efforts to extend the 3D printed applicators to the forearm. And so because it's a challenging area to treat due to the curved surface, as well as the radiosensitive organs at risk in close proximity, and that is the bone. And this has increased radiation absorption due to the high calcium content, greater turnover in the trabecular bone after radiation exposure. And this can lead to increased fractures in the bone, which with elderly patients often can be quite a problem, as well as it alters the bone marrow environment impairing cell production, leading to hematologic toxicity of the bone marrow. So the main aims was to construct an anatomically accurate forearm phantom using 3D printing and test the feasibility of 3D printed superficial applicators and compare them to other treatment modalities. So the three aims were design and fabricate a phantom by investigating tissue equivalency in 3D printed filaments, construct a novel 3D printed applicator for Brachy of the forearm, as well as create and conduct the treatment across the three modalities for the final comparison. So what this was, we separated into Brachy, VMAT, and Electron therapy. All of these were analyzed with current film, and then compared for Brachy was to TG43, the water-based dose calculation, Accurus Brachyvision, which is a model-based, same with Accurus XB for VMAT model-based, and then Electron therapy is Electron Monte Carlo. So investigating the tissue equivalency through infill, the following filaments were printed using the bamboo X1 carbon with a rectilinear infill pattern and underwent a Hounsfield Unit analysis. So this was the beige bamboo polylactic acid, or PLA, as shown on the right for the CT phantom, and printed at infill densities ranging from 5 to 100%, as well as the granite stone fill PLA. So this is a PLA with 50% crushed stone within it to increase the density. We utilize those from John Stone's research, which was printed from 65 to 100%. And these underwent a head and neck CT scan, and these scans were analyzed in ImageJ. So on the left, we have the regression of the beige PLA HU versus infill, and on the right, the stone PLA HU versus infill. Both examples exhibited linear dependencies of HU on the infill. Stone fill has a higher HU as well as gradient due to the density of it, and likely higher effective atomic number due to the stone crushed up inside of it. And so these had very high coefficients of variability, and is consistent with literature that have been done previously. And from this, we can calculate the optimal infill densities to correlate with our selected HU values. And so we needed to undergo an experimental tissue analysis. So a patient CT was analyzed to get HU values for specific regions. So this was the marrow, the soft tissue, and the bone, and these came to -41, 51, and 760-ish across these three regions. And these were compared to HU values found in the literature. So for soft tissue, it was found to be between 50 and 60. Marrow, being yellow and red, were -49 and -79, and then the two different types of bone, cortical and cancellous, were all the way up at 1800 and down at 344. And so comparing these and making small adjustments, the target HUs became 51, 766, and -50 for the marrow, bone, and soft tissue. And then using our graphs, we could extrapolate the infill density to be 85, 100%, and 76%. Using the patient CT from the TCIA dataset, we can segment these different regions and export these DICOM segmentations as STL files for us to print. So these were printed at their respective infill densities and separated into slices using the bamboo cut, as well as the connectors with appropriate tolerances for them to fit between each other. So here we have just all the slices separated out, the frame that was built, and then the final full complete phantom there. So the cost and duration of this, the total phantom cost around $120 for experimental filament as well as the entire phantom, and the total print time was approximately 68 hours. We did an infill verification on the HU to see how close it was. So soft tissue came to about 30 HU, which in the same paper that mentioned the 50 to 60 said it can drop below this value when adipose tissue is found to be in the soft tissue region. So this actually correlates well with that anyway. Bone was found to be the biggest discrepancy, down at 275, but this still remains in the range of the HU values for bone specified by Jung. So then for the applicator, we use TPU, which is thermoplastic polyurethane, and this is the first time I could find anything in the literature that had used a flexible filament for the 3D printed applicators. So this underwent the same method as before to obtain an infill versus density HU curve, and we wanted to print this applicator so it would be 0 HU, as this is the hospital's target value when doing brachytherapy. And so, yeah, same methods, we can extrapolate straight off the graph to get an infill density of 93%. So the applicator was fabricated in line with hospital quality assurance protocols using mesh mixer and fusion, creating the specified bolus thickness. And upon analysis, it remained within the range of the plus or minus 100 HU that is specified. For this, a roll of TPU cost $25. About half of this was used for the full applicator, and the duration of the print was around 22 hours, which TPU has to be printed quite slow to reduce stringing and other inconsistencies. So had to undergo treatment planning. So a typical forearm lesion was chosen by Dr. Das, prescribed 45 gray over 15 fractions at a depth of 5 millimeters. 2 planning CTs were taken, one with a copper wire outlining the region, as well as one with the applicator for the brachytherapy source planning. Films were cut for calibration as well as to fit in between the slices of the phantom, as that's where we'd be measuring. And then, yeah, so we did the treatment delivery and just experimental setups here. It's all the catheters hooked up for brachytherapy. We have electron therapy in the middle and then VMAT on the right. So to extract our results, we were comparing the treatment planning system to the experimental results. And so the treatment planning system, a Python program was developed to import the structure files, the planning files, and the dose files, and extract it exact as Z-axis values, the dose plane, the body mask, and the region of interest marks. And so that's what they look like once exported just in an array. And these were multiplied against each other to get rich dose values and statistics for these ROIs. The film dose extraction, another Python GUI was written to extract from the films. And so the process is just like this. The tip scans of the films were imported, as well as the body mask. Oops, sorry, this one here. And you click and drag to select the film that you are analyzing. This is thresholded to create an outline to register against. And then a auto alignment as well as manual alignment are available. This gets aligned using a course define registration. And then we import the rest of the masks that we'd exported from the treatment planning system to overlay into the film space that had been correlated with the overlap of the body mask and the film. And so we apply a 3x3 median filter as well as the coefficients for the film calibration for each treatment type. And this outputs the dose statistics for all of these regions of interest, as well as isodose pixel counts at these reference values. And so these were collated into 7 in-field film regions, as well as 4 out-of-field film regions. So just before we go over the results, I'll point out here, so this one here is the radius, that one there is the ulna, and the treatment area was up around here. So what we notice is all modalities actually achieved target coverage close to the prescribed 3 dose, as seen as in the dotted line at the top. And the target coverage never actually deviated by more than 5% across all 3 of them. VMAT produced the lowest in-field bone and marrow doses overall, demonstrating the improved sparing of the deeper tissues while maintaining the target coverage. And what it overall shows the experimental film measurements generally followed the TPS trend, supporting the phantom's ability to reproduce modality-specific dose behavior. Across all of them, well, not all of them, across brachytherapy and VMAT, none of the dose values actually deviate by more than 0.2 gray, but Electron does deviate at the radius and ulnar, radius, bone, and marrow regions. And then we have our out-of-field results here as well. And so the Electron actually shows the lateral scatter. Only the 2 bottom films included marrow. And because they're quite high error bars, the close one demonstrates a much higher dose in these lateral regions close to the treatment planning the treatment area. And VMAT produces the lowest outer field doses, suggesting the better sparing of the adjacent structures through the beam modulation, although brachytherapy isn't too far behind on that metric. So we also calculated the conformity of each modality across multiple isodose thresholds. And so the conformity index describes how closely the high dose regions conforms to the planned target volume. And the equation there comes from ICRU report 91. And what this is an inverse of the pattern conformity index, which is a multiplication of the coverage and the spill factors. So coverage looking at target pixels receiving reference isodose compared to the total target volume pixels. And then the spill is the target pixels receiving reference isodose compared to all pixels receiving reference isodose. So conformity really does depend strongly on what is the definition of the prescription isodose. So they are all planned different. So VMAT is planned 95% to the PTV, Electron is 90% to the PTV, and then 100% skin dose is what's planned for brachytherapy. And this equates to about 80 or 85% to the PTV. And as we expect, the best planned conformity aligns with the isodose that is normally planned for. However, VMAT has the lowest CI for the relevant isodose, but TG43 and Brachyvision are actually in better agreement with the experimental film values as seen over here, suggesting that it correlates better with what's actually being found experimentally. And then the last factor we have to consider is the spill factor. So again, that's the relationship between the number of target pixels receiving the reference isodose compared to all the pixels receiving the reference isodose. And we can see brachytherapy maintains the highest confinement of the high dose regions to the target in both the planning and experimental values. So from 95 ranging down to 80, the high dose regions are confined to that PTV, whereas this is a lot lower in VMAT and Electron. So this shows that high dose sparing of normal tissue that's usually associated with brachytherapy, being that steep dose fall off. We do notice that VMAT is slightly better at the 50% isodose reference point. So a little less low dose sparing of brachy compared to VMAT there. And so just in terms of clinical context on bone marrow dosage, the V10 and V20 are commonly cited limits in the literature, and these are denoted with hematologic toxicity of the bone marrow. And this is because we want to limit the dose to the white blood cells or the lymphocytes, as these are some of the most radiosensitive cells in the body, and this can lead to lymphopenia if overdosed. And so this transparent red band shows the V10 and V20 bounds as a per fraction dose, as our experimental films were only done over one fraction. And also cited is the max dose across all fractions usually kept below 30. And we can see from the graph that Electron quite often states this limit, but Brachy and VMAT remain within or just slightly over the limit in the close proximity regions, but under it in the further proximity regions. So for a final recommendation, we have to consider all conformity, dose fill, and dose to organs at risk. And so brachytherapy has the highest agreement to the planned conformity. And although it has a lower 50% isodose spill factor, the high dose spill factor of brachy is superior to the other treatment modalities. And VMAT actually has the highest organ at risk sparing, but this will be talked about a little later in the limitations. So clinical factors as well have to be taken into account. So scattering and exit dose when utilizing external beam techniques weren't taken into account. And the setup uncertainties in VMAT and Electron. It was already pretty difficult to line up the Electron field beam with the phantom. So I can't imagine how much more difficult it would be for a patient actually moving around. Time of treatment does need to be taken into account. VMAT and Electron are relatively short and consistent no matter the lesion size, whereas brachytherapy will increase or decrease depending on the lesion size as well as the source activity. And the main thing I think is the shielding availability in brachytherapy. If you're treating a arm, you can shield the rest of the body. However, this would be a bit difficult when you're doing external beam therapies. So as a final recommendation, I think including the clinical factors, brachytherapy using these 3D printed applicators for the forearm is very feasible, but it will depend on the lesion size, I think, which is discussed in a second. So one of the limitations is the unexpected discrepancy between the predicted bone HU value and actual bone tissue, and most likely this comes down to stone fill batch variability, as John Stone had pointed out in his research. There are inherent uncertainties in the EBT3 film, which is approximately 3.2% when you analyze the red channel. There's registration uncertainties that come from the movement of the film on the phantom, as well as the registration of the film to the body masks in the GUI. One big one is we only used one dosimeter, so that only gave us one kind of comparison point. And then also the biggest one is only one lesion size is analyzed. So when I was talking about the dose to organs at risk from VMAT, if it was a smaller lesion, that still might have that penetration, whereas brachytherapy might not. And so looking at smaller and larger lesion size would be needed. So future work, one thing would be investigate the validity of metal composite 3D printed filaments for bone tissue replication, and this can increase the HU. Enhance the comparisons by incorporation of additional dosimeters, just to give additional metrics to compare against, as well as utilizing maybe Monte Carlo modeling to give another modeling aspect. So repeat for larger and smaller lesions. This will be, I think, one of the determining factors, the conformality, as well as the deeper dose, depending on how long and how large the treatments are. And then finally, adapting this phantom methodology to a head phantom for use in brachy, because of the air gaps present in your head, in your nose. These would want to be looked at, given TG43 is used currently and doesn't account for these air gaps. So just as a conclusion, that first aim was to design and fabricate the phantom, which we were able to do to a high standard. Construct this 3D printed applicator, which was kept within all hospital protocol limits, and then conduct treatment across these three modalities, which we found brachy seemed to be the superior one, depending on lesion size. Just some acknowledgements, my supervisors, Pedro and Luke, massive help, and it couldn't be done without you, and especially Luke for doing all the treatment planning. UWA for providing all the printers for the majority of this project. Dr. Josh Das for doing the lesions, as well as giving insight into how the results would impact a recommendation. Charles Gardner Hospital for providing the film, as well as resources to conduct the treatments. And all those people there, you've helped in some way, so thank you to you. Charlie's Foundation for Research, and especially Godfrey for teaching brachytherapy. So there's references, and yeah, thank you very much.
That's a lot of that was correct. Any questions from the audience?
Yes.
We've been speaking a lot about your project the last couple of weeks, and you mentioned that actually start will be used clinically.
Potentially, we hope so.
So what would it actually look like? Would it be like a CT scan and then just bring it with the applicator?
So I've actually got, where is it? This one here. So what they do here is they use a optical scanner to scan the area, and they can actually outline the lesion with that scanner. And then that scan is what gets put, is what the applicator gets made from. And then you then have the planning CT from that. So it's not an applicator made from a CT, so you don't need to. It's just a optical scan that they do.
Yeah, great.
Thank you.
I had a question about the 3D printing of the bone.
Yes.
So like you mentioned, there are two types of bones with the different HU, and yours was kind of midway.
Yeah.
How did you decide that, and how does that represent that anatomy in the forearm?
So when I calculated the target HU, I just used a thresholded value across the whole forearm region, and that's why it gave probably a middle value. And I think the decision of that is just, it was the easiest to do that, as printing those different regions would already be difficult with stone fill, so I just kept it the same throughout.
Sounds good.
Might add something.
Yes.
So in comparing the Brachy to the Electron VMAT, that was all comparing to a single superficial lesion.
Yes. Yeah.
It was bolus used in the Electron.
For both of them, yeah. They were created by Luke, and then I printed it out and we attached it to both of them using the shown in the the experiment itself. So we had the bolus there, and you can see it on the VMAT one as well.
Bolus was TP.
Bolus was TPU as well, just to maintain consistency with the applicator.
And you were taking measurements to the edge of that bolus in the Electron case as well.
So again, sorry.
Like the Electron bolus probably could extend a couple centimeters for the student edge.
Around the arm.
Yeah, or maybe up and down in this photo.
Oh, okay. Yeah.
Would that have affected the results? Here?
Um.
I guess which were the main pieces of film that you were taking?
So the Electron case, the film went up to this one and down to this one. So yeah, there might have been more scatter out towards these two that could have been covered by more bolus. So yeah, it could have increased the dose of those out of field ones if less bolus was there. So yeah, it could have been increased maybe to reduce that at those points.
And I think it was slide 20 or so, you had the, go back one.
This one or
Yeah, that one.
yes.
So are we overlaying the film results directly on top of that image, or is that doing the film analysis in there as well?
That's doing the film analysis in there. So it overlays those regions of interest from the treatment planning system, and it puts them into the film space. And so it's using the pixels in those regions, but from the TIT scan.
So the calibration isn't being done on a hypothetical result, or is it being done?
Yeah, I did a calibration myself. Yeah.
And that was validated against the clinical system?
No, it wasn't actually. Oh no, we had a quick look between Film Wizard and mine, and I think actually we did one graph and the net OD versus dose looked pretty similar. I think
Quite well aligned.
yeah,
I mean,
it wasn't a proper verification. It was like a eye test, but they looked relatively similar actually. Yeah.
In terms of absolute dose as well?
No, we didn't use the film analysis Film Wizard software for that. It was just the calibration. Thank you very much.
Thanks, Dash. Well done. Well, that concludes the session. Thanks very much, everyone.